Good. So,
All right.
hello, everyone. I am Dr. Dana Mincer, the host of the Unfiltered Doctor podcast. I also own Love Health Direct Primary Care with locations in Fort Washington and Doylestown, Pennsylvania. Today, we are joined by Patrick Haig, CEO and co-founder of Goodbill, a company transforming how Americans navigate and reduce hospital bills. Founded in 2021 by Patrick and CTO Ian Sefferman, Goodbill helps both individuals and health plans uncover billing errors, negotiate fair prices, and really save money across the entire healthcare system. By integrating directly with third-party administrators, Goodbill partners with employers to ensure their employees get the support they need when facing complex or inflated medical charges. And there are definitely a lot of the inflated medical charges. Patrick brings a wealth of experience in technology and consumer advocacy to Goodbill's mission, making healthcare billing transparent, accurate, and humane. So hi, welcome.
Thanks, Dana. Thanks for having me on.
Thank you so much for coming on. I'm so excited to talk to you. So let's just jump into it. I think like what you're doing was so inspiring to me. I came across Leslie at the Goodbill booth in Denver at Health Rosetta Fest conference, and I'm curious to know if you can sort of tell us a little bit more about your why behind founding Goodbill. What drives you? Who are you? Because usually in this business, there's like most people are very much mission based. There's something that's driving them.
Yeah. So I'll kind of like tell this story through the lens of my co-founder and I, because we've been together for 13 years. I actually dropped out of law school to join him at his first company 13 years ago. Last year of law school, I made it through 2 of the 3. So the ending of 3L, that was it. So we built a marketing tech company. We sold it to an ad tech company or an ad tech, and SaaS, software as a service type businesses, fantastic. We learned a lot. And then coming out in 2018, we were like, we're kind of done with those industries. And actually, DPC was our first entree to healthcare. Total neophytes, right? 2018, helping another founder stand up a business in DPC, and we became enamored with both, I think, the scope and magnitude of the impact, and for better or for worse, I think like being software people, we kept running into like, we think like that's a problem, and like we think that's a problem, and that's a problem. And that in today's problem set, it's just leading to increased costs, however you want to define those increased costs. But DPC was our lens of like cluing into healthcare and seeing what, although we didn't know it then, what something could be. Like primary care, like direct primary care is still like a nascent model. We're like, this is incredible. Easy access, like fantastic patient experience. We immediately became patients of DPC physicians. And then on the financial side, the cost side was very easy. Like the story I tell is, this is 2019. Wife is pregnant with our first, and I go into my DPC and he's like, hey, when was the last time you had your Tdap? And I was like, like everybody, they're like, I don't know. And he's like, okay, it sounds like it's been a bit. You want it today? It'd be $35. I'll just charge the card on file. I was like, yeah, okay. He's like, cool. At least at that time it was pants down. I was like, all right, cool. Yeah. That was so easy, right? Like that was seamless. There was no claim. There was no EOB. There was nothing. It was $35. It was a very reasonable rate. And coming out of that, it was, as we expanded beyond that business, like after that business and hitting the more like 98% of the industry on fee for service, it was like, oh, okay, this is different. And the sheer scale of it all from a data perspective, and we're like data and workflow gluttons for punishment. There was so much to sink your teeth into. And we were like, we think we have an avenue here to automate a lot of things. And that was the genesis of Goodbill. It was like totally, I think, like a naive start, although we like to go very deep. And so that's what we did. We just started going very deep into how is a bill constructed? Like, how does it get to where it is? What do these numbers mean? Where do they come from? Both code sets, bill charges, negotiated rates, all of it. And that's how we became enamored with the problem of, we think we could automate a lot of this for people. And we know that there's like a certain percentage of Americans that just will constantly run their head against the system, trying to reduce the cost of it. So that was our first take at the problem.
Interesting. So you understand how complex the and how convoluted the system is. I still, even as a physician who's very much into the brokerage space as well, I still have a very hard time wrapping my head around how to explain those inflated costs to people. Like, I don't even know, other than the simplistic version of it is, well, this is the actual cost and this is what's charged through typical standard BUCA plans, and the middleman takes the difference. And I know it's not exactly correct in all circumstances, but I don't know how else to explain the absurdity of like what's happening with prices in a lot of situations. Other than if you experience it firsthand. Yeah.
It's crazy complex. It's like crazy. I don't think there is a simple explanation other than to say like, wow, that number feels pretty high, and it feels a lot higher than maybe it should.
Yeah.
Definitely higher than it should. So like that was part of it too, is I think you have this divide between, like, it is just a complex system and it's far too much for people to, I think, like day to day, unless you're spending, like I think about this 24 hours a day. I know my co-founder, Ian, he thinks about it 24 hours a day. Unless you're thinking about, like, you're a physician in the industry, unless you're thinking about it every single day, it's really hard to wrap your head around everything. But I mean, I think it's a function of, you have negotiation games where let's talk about like health system hospital rates, which are some of the biggest. You have a negotiation game, jockeying of position. You have market to market, city to city. There are different dynamics of power. Who has power in that city or that region? Is it a payer? Is it a health plan or an insurer? Is it a health system that's consolidated and they have a lot of bargaining power? It's who's jockeying for position for a specific rate set. Can that health plan negotiate a really good rate? And then for a patient, for a consumer, do you have a plan that covers a lot, or do you have a plan that covers a little? Like, there's just so much into it.
Yeah, and I think the biggest thing is like the quantity of healthcare debt that people have. I mean, it's putting some people into bankruptcy, and it really shouldn't be. That's the down, like the bottom line is, it should not be putting anybody in bankruptcy. Yeah. And especially with costs that aren't actual costs. So that's what really fascinated me when I found you guys. I was like, okay, well, I sort of understand that they're working with. Maybe you can explain, if I was not a doctor, not in the brokerage space within Health Rosetta, like nothing, like how would Goodbill work for me as an individual?
We just want to make sure that the price you pay is as low as it can be, fairly so. Like, that's it. Help you pay less on that bill, because usually that balance has a whole lot in it. Whether it be inflated rate, like it's just not a good negotiated rate because you don't have access to good negotiated rates, or the starting price is really high, or there are actually errors, or did you know there's this thing over here that if you had known about and you had applied for, but of course it's not very easy to apply for, you could have your entire balance waived and written off, so you have to pay anything. Right. Like, there are so many different tools and data sets to bring to bear on behalf of a patient. Our job is just to bring it all into one place and then do it for you. Because again, people, like, we're not trying to turn consumers into weekend warriors on medical billing. Like, to solve the problem.
Yeah. This is like years and years and years of education and learning. And it's so complicated that it's just nice to have somebody fighting on your behalf, essentially. And I also think the important thing is for most people to realize that, in my experience, most initial bills that you would get, and I navigated the system myself leading up to a hysterectomy in February, and thankfully I had a health sharing plan to back me up, right? But you're still seeing these bills come in, and like just realizing that most of them can be upwards of 5 to 10 times more than what the like actual cost should be. Yeah. And so that's nice to know that patients can simply just contact you to get some assistance in decreasing their bills. I think the other important thing that I talked with Leslie about was, maybe you can explain briefly the, what did she say? Is it 501R? Differences between hospital systems, and how your website has the ability to, for example, if you're in that lower income bracket, you can search for one of these hospitals. Can you take viewers through that a little bit?
Yeah, I'll do like a 501R primer, and then what does Goodbill do with that? So 501R, it's IRS section 501R. It's an IRS regulation that applies to all nonprofit hospitals. Turns out that's about 60% of the hospitals in this country. About 80% of hospital beds are at nonprofit hospitals. So like the largest ones tend to be nonprofit hospitals. I think in your neck of the woods, that'd be a UPMC, it'd be a UPenn or Penn, it'd be a Geisinger. Those are all nonprofits. And the law says, okay, nonprofits, you're going to get tax exempt status. So you're going to get tax breaks. We want you to justify that, to show that you're putting out into the community benefit. You're not being tax exempt and adding burden to where you're practicing. And so it says you have to have a financial assistance policy. And when you have that policy, it has to limit charges and relieve patients of financial burden where they qualify. And it turns out most hospitals, I think, hospitals aligned on one way of determining whether people are eligible, is if you make below a certain threshold, you don't have to pay some, or all of your balance, and the charges will be limited accordingly. So that's 501R. Like a nonprofit has to offer those programs, and they have to make reasonable efforts to make people aware of them.
Right.
I think, chalk it up to what you will. Not always easily done. Most people are not aware of those programs. And even if you are aware, not a very easy process to go through, which is where we come in terms of like our story as a business as we started direct to consumer, and we levied that strategy against a balance. But it turns out health plans are value aligned with this in terms of reducing costs. So they're also in the right position as people are using their health plan and getting care. You can use 501R to limit charges. And we kind of streamline that to make it a consumer grade experience versus a bunch of PDFs and faxes.
Right. Interesting. Okay. And how often do you think, like, of the reviews that you do, how often are you guys able to actually decrease spills?
60% plus.
That's a huge number.
Yeah. Like 501R alone, you're talking about 45, I'd say half of the country is likely eligible for 501R.
That's amazing. And then,
it's insane.
Yeah. And so, regarding your integration, I did want to know also just a little bit more about your integration with EMRs, because I actually used to have Atlas MD for various reasons. And I love those guys. They're wonderful. For various reasons, I felt like I had to switch just because I needed more options to demonstrate return on investment for employers in case they wanted it, with CPT codes and such. But how does that work? How does the integration, what does it look like?
Oh, yeah. So from that type of EMR integration, kind of, and massive credit to Atlas MD and Josh and crew for seeing this and working with us on this, is that we found, and back to DPCs, of like, a DPC physician is in a very unique position to want to be a one-stop shop, has the time to be a one-stop shop. And so the thought there was, well, DPCs are helping patients navigate the clinical side of care. There is absolutely a financial side of care. So how could we surface all the data that we, Goodbill, have amassed and indexed in a physician's workflow at the right point? So that a physician can not only counsel a patient on the clinical side of things, but also like, okay, like, for example, I really don't want to refer you out to a health system, but I may have to for X, Y, or Z reason. How could I make it in my flow, one click to know whether you might be eligible for discounted care at a local hospital? Like that quickly. Because I think another truth is, like, physicians are going to stick to their workflows, and you have to make it easy for everybody to transact. And so that was the genesis of that integration. We have other types of EHR integrations, but that was that.
Oh, interesting. Okay. Yeah. I mean, that is a significant portion. I have more and more patients coming to me with either health sharing plans in which it's really important that they know costs. And other than like I love talking to people. So I will just go knock on people's doors and be like, hey, an imaging center opens up. Hey, who are you? Who's the owner? Can I have their number? I'm Dr. So-and-so. Like, I love that type of, and can I get some cash pay prices? Like, just give me a list of things. But that's super helpful in terms of the larger things that do require hospital systems, because it's sort of overwhelming. It's like, well, most of the health systems around us, at least, they are not transparent with their costs. I mean, it's Jefferson. Holy Redeemer is a bit better. They're like one of the few independent systems that are left standing, and are able to give some, actual decent cash pay costs in advance. But that's super helpful. So then what are the other integrations that you're saying, other than so I guess, hold on, let me step back a second. So Atlas MD, are you planning on working with more electronic medical record systems in the future?
We're definitely open to it. I think it's like we're still in the early stages of this type of story playing out. I think even maybe, I mean, I would love to hear your opinion on this, of the physician stance on where do you draw the line between counseling on clinical versus the financial side of care too? Do you want to go hook, line, and sinker? Do you want to mix the two? Is that dangerous? I think it's a really fascinating place, because I think on one hand you have the consumer side of things where if I were to go back 5 years, 7 years, I'm looking at my physician for everything. What do I need? Why? And then, okay, where should I go to get it? Because I obviously have no idea. And then more and more, I think the conversation is becoming, I obviously want to go somewhere that's good, but I also don't want to pay out of the nose. So can you help me? But I'm curious, like, what you think on that, of like, is there a line?
I think that's very physician dependent. They always say, like, once you've seen one direct primary care practice, you've seen one direct primary care practice. For me, that's extremely important. We're very much mission based, and we, have been really pushing to work direct with employers. We have a couple of other companies that we're working with as well, like Appley, for example. And I just think it's not just from the employer side, but it's so, I just believe it's so important for people to know the actual cost of goods.
Yep.
It is absurd. This is the only industry in which you go into getting care and you're a consumer and you consume without knowing the cost. It is like, when I put things in those terms for people, they're like, oh, I was like, would you go to the grocery store and do that? No. Would you go? So for me and for our practice, it's really important that we are care. I always say we're care and cost navigators.
Yeah.
Like, you don't have to sacrifice one or the other. It can be a win-win on both sides. That's what my whole life right now is about. How do we make this a win-win situation for everyone? Same thing with care and cost. You can have both. So I think that I don't know if other DPCs, I think that the DPCs that are going to be likely to be most successful are the ones that are going to be able to cost navigate effectively as well and do both. Yeah. So, so interesting. Well, and so in terms of your platform, I'm curious to know more about, like, how do you do that? How do you use AI? Do you use data analytics? Like, I'm trying to wrap my head around how you even created a system. I mean, are people calling directly? Do you have people calling hospital systems to be like, yo, you need to negotiate with us? Like, how does that even work on the back end?
We absolutely have people who call hospitals. You can't, some of that you can automate, some you cannot. Like our core way of operating is we integrate with how a plan runs. So we're usually dealing with claims, and claims are the way we might think about it is like just a trigger. It's a trigger to reach out and say, hey, Danny, so I went to the hospital. We want to save you some money here. And here, click into this flow that we've streamlined and make that happen. On the back end, there is absolutely AI. There's loads of non-AI automation as well as LLM driven or AI driven automation. But it's identifying kind of like the right course of action given a claim, given a group, given a member, given a facility, to get to the point of this is the best strategy to reduce the costs. Here's how to go do that.
So it's not a one-stop shop. This is very complex and intricate basically. This is not
It's pretty complex.
Yeah. So then how did this all I mean, okay, so take it, you guys had an idea, right? You had this idea that came to mind. How do you then go from an idea to actually putting this into practice with a company? Were you guys were you and Ian the ones doing the navigation at first? Like, I'm trying to wrap my head around how it goes. Yeah.
Yeah, you just start. I think like part of, if you say, okay, I'm going to automate that thing, the first thing you do is you go do that thing manually, because you need to understand every single step, every in and out. That's what we did. We looked at each other. We're like, yeah, okay, we want to go do this. Great. Let's start helping people with hospital bills. And maybe even back then we weren't even so sophisticated. We're like, I don't know, any medical bill, like anything. But there was actually one, it was our first hospital patient had a bill for, in aggregate across multiple days of service, about $60K. And like I would basically work it and then turn to Ian and be like, okay, clearly like we need to build something here because this is insane. He'd build it, ship it, keep working it, and basically do that back and forth until you get to something. And it was something as simple as like, oh, we need to go get an itemized bill and a claim. How do we go do that? Oh, where do we send that? How do we send that? In what way? How do we get it back? What do we do with it? How do we structure it? It was just literally that infinite number of times until we're like, okay, we think we understand the process now. And then you get to a scalable way of doing things. And you just rinse and repeat that on many different kind of layers of the business until we were like, okay, we think we have a product here. That's literally how we got started. And
wow.
There's not a week that goes by that we don't look at each other and we're like, that was crazy when we learned something new. When we learn something new every single week. And usually we're turning to each other and going like, who would have thought? Like, who would have thought? It's not intuitive.
Yeah. That's really interesting. And so your background though, so you you said you finished 2 years of law school and then you dropped out. Did you ever go back, by the way?
No.
Okay.
No, I'm not a lawyer. None of this is legal advice. Caveat.
So then, but you said right after law school, what were you doing after you dropped? You dropped out to do this company, or you dropped out to do something else?
No, to do something else. I dropped out. It was 2012. I dropped out to join Ian at his startup.
Oh, got it. Okay.
Yeah, I was in marketing technology. That was the first like non-technical hire. So basically doing whatever to help the business grow.
Interesting. Okay. And Ian has a tech background. Is that his?
Yeah, engineer by training and trade.
Got it.
But absolutely business partner through and through in the whole biggest sense of that word. But an engineer.
Yeah, that's amazing to have that. I think that's like when you have an engineer by your side as well, you're blessed with a very logical way of thinking things through. It's like very systematic, and even CPAs as well, accountants. Like I have one of those, and really helpful to like, especially as an ideas person. As I consider myself the visionary, it's nice to have an integrator.
Yeah, it's like what are the two most influential decisions you make? Number one is picking your life partner. I would argue number two is picking my business partner, and he picking me mutually, of course. Then you get to say, cool. We're a team. Let's go focus on the problems in the world that we want to tackle.
Yeah, that's amazing. And so I had more questions for you. I don't know if you have anything else you want to talk about. I was going to go into a little bit. I don't know what you know about the Consolidated Appropriations Act.
A little bit.
And, I think like my understanding, and I'm not a lawyer or never have I ever gone to law school. I've thought about it though, actually.
Oh man, I had one MD JD in my class, and I was like, "You're crazy."
I'm just so pissed off and that at the system right now that I've been thinking about, could I make more of an impact if I had some legal background as well, and then I could just start really implementing change in this arena. I don't know. Our arena is in Pennsylvania. It's really messed up. It's very much a cartel, And I say that very openly. I mean, I'll give you a quick story before I go back to that question, but we were negotiating or attempting to negotiate and show one of our few independent hospital systems. We had the attention of the chiefs of, and how they could possibly transition off of their self-funded plan that's administered by Blue Cross to a self-funded plan that's administered by a transparent third-party administrator and lower their overall health spend for their health plan for their employees, right? Because it's always absurd to me when you and this is the situation a lot here in Pennsylvania, where physician practices, hospitals, this hospital is really suffering and like having a bit of a hard time financially, that we have no other independents left. And they're suffering because they're begging for appropriate reimbursement from Blue Cross. Yet they're now paying for Blue Cross to be their like health plan administrator for their employees. It's like the worst narcissistic relationship that you could ever be in, right? It's like, it doesn't even make sense. And from a mission-based perspective, you're now supporting an organization that's like totally screwing you over. But I'll leave it here that one of the concerns if they switched off of Blue Cross was retaliation in the form of like payments. Like that is how mafioso and cartelish it is. And this is coming from like the admin at the hospital. It was a valid concern that in this arena. So I think there's a lot of really much stronger forces than people think. And when I talk about the large 5 health insurance companies, I do acknowledge that there are going to be people that may need that as their plan. But I also acknowledge that it is one of the largest legal cartels that ever existed, in my opinion. So that being said, there was this Consolidated Appropriations Act passed, right? And it was supposed to bring more laws around forcing hospital systems and providers to be transparent about their prices. Is that correct?
You had transparency and coverage on the payer side. You had hospital price transparency on the provider side. And then you had the CAA, which I think is a combo. It's at least the part that I know most is basically saying, hey, people that work with and sell to employers, typically self-funded plans, you can't hide the ball anymore, and you can't say that you're hiding the ball anymore, which is like you can't have gag clauses saying, no, you can't actually know that about your contract. And that's all like, what is the spirit of the policy? I think the spirit of the policy is saying, employers, you have this fiduciary duty to operate in the best interest of your plan and plan participants, which is your employees and their dependents that are on the plan. You can't really do that if you don't know what's going on, which means you don't have claims data, cost data, those types of things. And every layer in between is trying to not let you do that, whether it be a payer saying, no, you can't actually have access to your claims data, or I'm going to make it really painful or expensive for you to do so. Or there's no gag clause in this thing, but the document will make you sign to get access to your claims data has another gag clause in it. To also health system side saying, no, you can't tell anybody about these rates. No, you can't review these claims. Otherwise, we're not going to be in network on this thing. So you have both of these, I would say very powerful entrenched interests effectively saying, no, you can't have data. And the CAA was trying to say, let's like reverse that trend a little bit. I think there's legislation in progress to double down on that stance. I personally believe the whole transparency movement, like the train's left the station. It's just like, how fast is it going to move? But there's so much already. Like we're already starting to see, all the hospital price transparency data has been out for now about 5 years. It's having an impact. I'd say more like a reversion to a mean impact. Yeah, people are starting to see things. But do you
think they're gonna that the CAA is going to impact what you're doing in any way, shape, or form? Or you think it has nothing to do with the space that you're in?
I think it will. I think that our customer set who we work with are typically more like middle market employers that are working with independent third-party administrators that can have access to claims data. I think there are some TPAs that maybe don't want that as much, and I think that'll impact them. Where I think this is probably most impactful are the massive employers that are still placing their business with like a Blues and an administrative services only type arrangement, where they're admitting. I think that is where there's a lot of money there, and there's a lot of data there, and as that evolves, I think that'll make more of an impact up there. Because all people are trying to say is like, hey, should we just look at the data? And they're like, no, don't do that. Why would you want to do that?
Why would you want to do that? That doesn't make any sense. I mean, it is amazing how many employers are shocked to learn. And that's usually how I open the conversation with an employer is like, we're talking to CEOs and CFOs, and this is not their fault. This is just how it's been for a long time. And they're shocked to learn that they can legally audit their health plan claims. Like they have no idea that that's even. And when I look at them and say, well, how often do you review your financials for your business? And they're like, on a regular basis, of course, all the time. I said, well, when was the last time you reviewed the financials on your health plan that you're sponsoring? And they're like, I didn't know I had access to that data. And I'm like, yeah, you do. Even if you're just paying Blue Cross, like you should have access to the data.
Not that it'd be easy to find out you could, right? Because it's honestly a full-time job just to know and just to go do it. And then once you have it, you're like, oh, okay, now I have a spreadsheet of potentially hundreds of thousands, if not millions of things.
Yeah.
What do I do about it?
And I think some of the hesitations that people have are their stories about failed plans. So when I'm talking to employers about, hey, just so you know, like you might have a better situation if you push toward a self-funded situation, but you need to get off of this Blue Cross. You don't want Blue Cross administering, because anytime you use Blue Cross, United, Cigna, Aetna, Humana as your administrator, your costs are going to be, like 5 to 10 times higher. They're afraid to do that because they've heard stories of like botched like insurance, basically stop loss coverage, and then and they don't understand the reinsurance piece of it. But I was thinking, is that an area where you guys can affect a significant amount of change? Like, for example, if you're integrating into the third-party administrator way they're administering the plans, and somebody that you have that one out, and it's a self-funded plan, they're not on Blue Cross, they have their own stop loss coverage, they have their own reinsurance for the stop loss, and they have that one the outlier year where they have like, I don't know, two people that were hospitalized for something terrible. It seems like that could be where you guys come in and work on that issue.
Yeah, those are often the things we're brought in to do. We also operate as part of the plan. I think the employer dynamic of, number one, it's absolutely been an evolution of employers. You need to start taking a little more control over how this is running. And I think we've tended to see that the best plans are run as a second business, of like, you have an exec, whether it be chief HR or a chief benefits if it's of a large enough scale, whose job is to run that like a P&L. And that's what it is. And then they typically are tending to have let's go smallest year over year increases. Or maybe they see decreases. But I think part of that is taking that type of stance and adopting that type of mindset, which means probably pretty quickly when you adopt that mindset, you're going to realize that you're not really in the driver's seat and you don't have control. So then you'll shift plans to a place where you can have control. And then you'll probably start wanting to do things. And so then it means you're kind of either helping design a plan or working with those that have already architected and designed plans. But I think part of changing the mindset and the end outcome is experimenting with things. And some are going to work and some are not. But I think if you keep having kind of like a fear-driven mentality, you're probably going to stay with that ASO. You're probably going to stay with the BUCA carrier. Don't expect anything different than from a premium increase or like a total loss ratio perspective. It'll still be expensive.
Yeah, I agree. It's that fear that keeps you in that arena. Well, I guess I'm just aware of the time, and I know you have another meeting in 5 minutes. So I just I wanted to give you a chance to sort of I don't know, talk a little bit more about like anything exciting that you guys have on the horizon, any upcoming innovations or goals, and what are you looking forward to?
Yeah, we're excited to kind of increase like how many times we can potentially help a patient, help a member. I'd say we have always been automated. Like automation is very top of mind for us. I think AI is like, it's incredible given proper constraints. It's incredible. I would argue it has not nearly kind of penetrated our industry as much as it could or should. But we have a lot of fun AI-driven things around the corner because at the end of the day, all we're trying to do is apply downward pressure to cost, whether it be through hard claim cost or through administrative friction and cost. And I think there's a lot of room to go. So I'm most excited about that. If you're a DPC physician listening, an employer listening, a broker listening, a patient listening, number one, like start to engage in this topic. If you have the wherewithal and you have the pain, if you're an American, you probably have the pain. I just start peeling back the layers. It's an onion, just like keep going. And I think you're going to find a lot of people in a similar position.
Yeah. And I think that, that being said, in this whole arena, I've been so blessed. I feel so blessed every day because I'm just constantly meeting other people that are in this industry that are doing things from a mission-based perspective. They're like, yeah, we can create this business and make some money off of this, but we're also like, it's a win-win for everybody. We're doing something to make the world a better place. And obviously as a DPC physician myself, which is, I always say it's a very affordable concierge care in a way. We just don't bill insurance. My goal is to get this to everyone because everyone deserves to have time and space and appropriate care. That's just like the baseline level of where primary care should be. Yep. So I think the same is true with what you guys are doing. I'm excited to I don't know, I sort of was thinking more about your situation. I was like, I wonder if they're going to integrate with full on health, marketplaces where they can, I don't know. I was just I was thinking of all the different pairings that could be had between Goodbill and everything else that my brain is constantly going in this arena.
We have a very ambitious roadmap, but yes, I think that's it. Is how do we make sure we are helping design the best possible member patient experience from a financial perspective, and then using that to drive down costs like that. It is that simple and that complicated at the end of the day.
Yeah. And I think it's also just important that the last takeaway that I want for anybody listening is if you know someone that's in financial hardship, just call. Call these guys and just who knows, you don't know unless you ask to see if somebody, when you reach out to see if somebody can help you, but don't just accept that bill as the bottom line. Don't be intimidated by the collections companies that are calling you, and just, reach out and ask, and, you never know.
So much of the world is that. Yeah. If you have anything like that, goodbill.com.
Yeah. 100%.
So,
okay.
Dana, thanks for having me.
Thank you so much. I really appreciate the conversation. Yeah, I really appreciate you taking the time to come on.
Of course. Anytime. It was fun.
Okay. Sounds good.